Welcome to this deep dive into fat grafting, where our clinical mission today is breaking down the critical techniques and variables, from small volume facial rejuvenation to mega volume breast reconstruction. We are focusing on exactly how you can optimize graft viability and avoid complications in your daily practice.
Yeah, and we really need to talk about this right now because, well, fat grafting used to be this completely unpredictable thing, right?
Right.
But now it is the absolute cornerstone of regenerative medicine.
It really is.
hmm
I mean, you look back at the history, and you have Neuber in 1893 reconstructing a depressed face.
Yeah.
But after that, the technique was largely abandoned. The early results were just pretty disappointing.
Oh, completely, because they didn't understand the variables yet until the Coleman technique arrived in the mid-90s and totally standardized facial grafting.
Right, but there's this weird 20-year gap. Breast and body grafting was basically ignored until, like, 2006 or 2007. Why did it take so long to make that jump from the face to the body?
Well, if we connect this to the bigger picture, the evolution was never just about moving larger volumes of tissue. It was a fundamental shift in understanding the regenerative aspects of fat.
Okay.
We realized it's a rich source of stem cells. It's not just a filler.
Okay, let's unpack this.
Yeah.
Because graft viability relies entirely on adequate vascularization.
Exactly.
So starting with the face, where the
Yeah.
focus is on small, precise volumes, like 20 to 60 cc. You don't need bulk, you need precision.
Right.
You prep your donor sites, hips, saddlebags, thighs, inner knee, with dilute lidocaine and epinephrine. But does it actually matter clinically where we harvest the fat from?
That's a debate you hear in the OR all the time, but the short answer is no. There's no clinical data proving one anatomic donor site is biologically superior for survival.
Oh, really?
Yeah. Here's the key point. The clinical priority is strictly about avoiding a concavity or dimpling deformity at the donor site.
That makes sense. And you're looking at a harvest to purified ratio of, what, 3 to 1?
Correct. You pull 90 cc to get 30 cc of usable fat.
Right. And then for processing, you're using gravity sedimentation and telfapad rolling.
Yeah, you roll it on the telfapad until the fat becomes really thick and bright yellow.
And then you inject using 1 cc syringes with blunt end cannulae.
Exactly. And you want to target deep compartments with low motion. The cheek, the malar region, the upper nasolabial folds, those have the best take.
Because motion is the enemy of graft take.
Exactly. High motion areas like the perioral region or lips are incredibly variable.
Right.
And common pitfall right here. The periorbital region is incredibly unforgiving.
Oh, yeah. The skin is so thin there.
Paper thin. In real life, injections here must be placed deep, specifically under the orbicularis oculi muscle.
Or else you risk inducing a mechanical ptosis from the sheer weight of the graft, right?
Exactly. Deep placement is mandatory.
Because when you lose precision in the face, things go south quickly. I mean, intravascular injection is rare, but it's devastating.
Devastating, which is why you have to use low-pressure layered injections with blunt cannulae.
Yeah. But then there's overgrafting, which we are seeing way more of now, especially in younger patients.
Right, because fat remembers where it came from. All fat grafts enlarged with weight gain.
Wow, yeah.
So if a 30-year-old gains 10 pounds a decade later, a superficial overfill will severely distort their face.
And trying to fix an overgrafted face with micro-liposuction later, I mean, it's basically like trying to unbake a cake.
Oh, absolutely.
You get minimal improvement, and you risk massive scar formation. The clinical mantra has to be under-promise, use small to moderate grafts, and minimal overfilling.
Underfill, always.
Here's where it gets really interesting, though. If we look at mega-volume grafting for breast reconstruction, we're jumping up to 700 cc.
Right.
And that highly concentrated facial approach,
Yeah.
it completely fails in the breast.
It's a totally different operation. In mega-volume grafting, optimizing the entire system is way more important than maximizing any single variable.
Right, like the processing. For the face, you centrifuge at 1300 G for 3 minutes. But for the breast,
You can't do that. It causes massive cellular damage and clumping. It ruins the flow.
so what do you do instead?
You spin 60 cc syringes at a very gentle 20 to 40 G.
Ah, okay. And the injection techniques change too. You've got reverse liposuction, which is constant motion, best for soft, unscarred tissue.
Right.
But if you're dealing with scarred beds, irradiated breasts, or over-implants, you use the mapping technique.
Yeah, where you inject on axial withdrawal only. You have to be meticulous.
So what does this all mean for the recipient site? You can't just pump 700 cc of fat into a tight, unexpanded breast envelope.
No, absolutely not. The VC ratio, the volume of the graft to the capacity of the recipient site, must never exceed 1:1.
Never exceed 1:1. Got it. And for irradiated breasts?
They have a much lower VC ratio. You're looking at 4 to 5 grafting sessions.
Wow, that's a lot of OR time. But you can pre-expand the tissue, right,
Right.
with the BRAVA external tissue expander.
Yes. The patient wears it 10 to 12 hours a day for months.
Which sounds intense.
It is. But what's fascinating here is how it drops the subcutaneous interstitial pressure. It essentially emancipates the surgeon from needing highly concentrated centrifuged fat.
Wait, really? Because the less concentrated fat flows easier into that expanded space.
Exactly. It reduces your OR time from 6 hours down to 2 hours.
That is a massive difference.
And you can use percutaneous 3D meshing to lease internal scar ligaments right after grafting.
Okay, we have to talk about the controversies, though. Cancer detection and stem cells.
Yep.
Because if we're injecting hundreds of cc's of fat into a breast...
Right, the ecologic implications.
Yeah. I mean, back in 1987, the ASPS actually condemned breast fat grafting due to calcification concerns.
They did. But current data shows that while calcifications happen 10 to 20% of the time in mega-volume cases, they're typically bioareata 1 or 2.
So they're easily distinguishable from malignancy on modern digital mammography.
Exactly. But this raises an important question about long-term safety. We really need a 40 to 50-year international registry to track cancer incidence.
For sure. And what about adipose stem cell enrichment? Are residents, focusing on that to increase viability via neodebogenesis?
It's heavily theorized, but it's not FDA approved or clinically proven yet. I firmly advise against using it in current practice.
So residents should just be focusing on technique refinement while the basic science catches up.
Yes. Surgical discipline over theoretical biology in the OR every time.
So wrapping up, respect the recipient site, tailor your processing to your specific volume, and never ever exceed your VC ratio.
Absolutely.
As our understanding of adipose tissue biology and neodepogenesis evolves, you really have to wonder, will external expansion devices eventually become entirely obsolete, replaced entirely by biochemical optimization of the recipient bed? Something to think about. Until next time, keep refining your technique.